improves patient mental health status, yields reduced hospitalization, and it's especially true for patients with complex medical needs. But CCP and programs, that are fully integrated are not necessarily appropriate for everyone. They aren't necessarily great for patients who are at lower risk of hospitalization or patients with a strong PCP relationship. So our goal was to develop a model that really leverages patient-provider and provider-provider relationships to achieve similar outcomes for patients that might have a lower risk of hospitalization but still have complex medical needs. Our goals were to facilitate provider-to-provider continuity, as well as, patient-to-provider continuity, as well as provider-to-provider. And more specifically, we wanted to maximize continuity between the inpatient and outpatient providers, as well as facilitate more seamless transitions between the inpatient and outpatient setting, both on admission, throughout hospitalization, and on discharge. We wanted to improve continuity of care within hospitalization, and as we've talked so much about this morning, we really wanted to leverage relationships. So at its base, the Rounder model, as we've conceived it, is really a reconceptualization and a reorganization of how hospital medicine care is delivered. So in the traditional hospitalist model, typically hospitalists work 7 days on, 7 days off. They've got long days when they work. They work about half the weekends a year and cover many patients a day. This yields many challenges. There are frequent handoffs among hospitalists, especially for complex patients who have long lengths of stay. There's poor continuity with outpatient clinicians, and there's a significant risk of burnout. So in the Rounder model that we conceptualized, we really redistributed work and coverage time. In this model, we have docs who work most weekdays a year, but work shorter days when working, only in the mornings. They hand their patients off to another group member in the afternoon and weekends. And with the schedule we put together, they work about a quarter of the weekends a year with the poor Rounder group, and they cover fewer patients a day. What this also enables is better linkage of Rounder clinicians to specific outpatient clinicians and patient populations. So in this figure, we've got 3 different Rounders that we depict. They can link up with different primary care groups, with specialist groups, or with particular patient populations, be it a sickle cell patient population or an ACO population. This really can increase provider-to-provider continuity and facilitate these inpatient-outpatient transitions, and also increase patient-to-provider continuity when patients have multiple admissions. So what does this actually look like for a patient who's hospitalized? So with the traditional hospitalist model, if someone's in our hospital for a couple of weeks, week 1, they'll see one hospitalist, week 2, they'll see another, and week 3, they'll see a third hospitalist. And these hospitalists will obviously talk to each other as they transition, but it'll still be a new person each week. With the Rounder model, if someone's here for several weeks, they'll really have one person driving their care with only small breaks on the weekend. We've also thought about how this model could work with a somewhat more traditional model where you've got 2 docs working together, each working sort of week on, week off. You could have these docs working together, but still taking care of a very specific patient population. So what's been our experience so far? We started the Rounder model back in April of 2022. We've got a 3-member group with a 4th member who covers for vacation time. We have primary Rounders who work all weekday mornings and 1 long week, including the afternoons and the weekend when they're not on vacation. And this coverage model looks very different to a traditional hospital medicine team. These Rounders only cover 6 patients a day, 15 on the weekends when they're covering for their colleagues, compared to 12 on a traditional service. Rounders are on service about 42 weeks a year, compared to about 26 weeks a year for a traditional hospitalist, with 30 short weeks and 10 long weeks. So again, only 10 weekends a year. And they also work a small number of additional shifts, like a swing shift or an evening shift, depending on their clinical load and clinical FTE. The covering role, on the other hand, consists of about 30 weeks a year, 23 short and 7 long. And we've covered this role primarily with one person, but occasionally with others, with the goal of helping to build a bench and having providers in case providers leave. We also have monthly meetings to address issues and push the model forward. At this point, we haven't linked these Rounders up with outpatient providers, but are planning to do so soon. We've really had minimal physician turnover, so the model has been pretty sustainable. So what have we learned? Our docs really report that they feel like they're better doctors. They've got increased control over patient care. Doctors really value the continuity in addition to patients. They've got the ability to form relationships with patients over a long hospitalization and see tough cases through to the end. They're not handing off these challenging patients. There are also fewer first days. When a hospitalist starts service with 12 new patients, it's pretty tough to get to know those people. So this has really led to decreased cognitive load and translates into more thinking about each case. We've also found that these docs have increased personal responsibility for their outcomes since they're seeing the case from beginning to end. Rounder has also proven to be a great solution for particularly complex cases. It's been an opportunity to improve patient continuity for patients who aren't in our CCP program. And I've got a couple of examples of that. So the first case is a young pregnant patient we took care of for many, many months at U of C with developmental delay. Given that she was pregnant, we weren't able to place her in a group home, so she really had to live in the hospital for about 6 months. This patient developed a very strong relationship with the rounder who was taking care of her throughout her multi-month hospitalization. She went to the obstetric service when she delivered, and then the obstetrics team specifically requested that she come back to the rounder team since she had such a great relationship with that doc. And we found that this rounder could effectively manage some pretty complex relationships with legal affairs, with the Office of the State Guardian, over time to really facilitate this patient's discharge as smoothly as possible. A second case is a patient who was frequently hospitalized for foreign body ingestion and oftentimes ingested objects in the hospital. This patient was readmitted many, many times over a couple of years and developed a very strong relationship with the particular rounder over these multiple hospitalizations. This rounder developed relationships with psychiatry consultants and nurses, and we found that over time, this patient had fewer hospitalizations and fewer ingestions while she was hospitalized because of this relationship. So the hospital is really starting to recognize the value and additional service that a team like this can provide. We've also found that the rounder has really demonstrated the value of small teams. Rounder has a collaborative culture. There are opportunities to ask questions and opinions of colleagues, and this is really encouraged by the short-term handoffs that these physicians have in the afternoon and on weekends. There's increased trust and accountability among providers. They're going to be coming back the next day, so if they don't give a great sign out, they're going to hear about it the next morning. They're going to come back on Monday. And this really drives improved performance. People don't want to let down their peers. We've also found that there's enhanced responsibility for continuous improvement, a strong desire to make the experience and the team better. This is these doctors' team. They want to make it as good as it can be. And as a result, we've really found that this team is a learning lab for innovations. As I mentioned, these rounders are in the hospital most days a year, and this daily presence really drives relationships sort of across the health system, obviously with patients, but we've also tried to co-locate this team on a particular unit. And that's led to really strong relationships with nurses, with physical therapists, with care coordinators, with outpatient physicians. And just being in the hospital so many days a year, these doctors are oftentimes looked at as leaders of the hospitalist group, and they really serve as consultants for their other hospitalist colleagues. The last thing I want to highlight as we think about implementation science is the potential value of Rounder as a bridge to a fully integrated CCP program. So as I mentioned, Rounders have the opportunity to develop relationships with both potential CCP patients, as well as outpatient providers. So as they work with particularly complex patients, there's the opportunity to develop Rounder panels that could then become CCP panels. Oftentimes, these patients are frequently hospitalized, are socially and medically complex, they're long stay, frequently admitted, sort of the ideal patient population for CCP. The afternoons that are free in this model many weeks a year also provide the opportunity to start outpatient clinics instead of these doctors serving other hospitalist shifts. You can have them staff a clinic, and it's a way to sort of start by having people in clinic 1 day a week, then 2 days a week, then 3 days a week. You can reduce their service time, reduce their other shifts, and really make this model economically feasible. So in theory, these docs can gradually transition from seeing Rounder patients in the morning to CCP patients. And there's always the opportunity with a model like this to support morning rounding with volume of patients that are not affiliated with either the Rounder or CCP program to continually make this model economically feasible. So as we think about next steps for the program, we're planning linkage to outpatient providers, including geriatrics and potentially other programs. We're really being deliberate about these choices, given the limited resource. It's just one service and 4 docs, so we've got to really think carefully. We're considering scaling based on provider interest and patient need, and we're also starting an evaluation. We're going to be looking at patient experience, readmission, length of stay. We've got some preliminary data, but are planning to get some more. So I will end things there as a brief overview of what we've been doing at U of C, and I will turn things over to Niraj to talk a little bit about what's going on at Kaiser.
Great, thank you so much. Can you guys hear me okay? So Niraj Mendurata, I'm the principal investigator for our complex care program, which I helped develop and start almost 8 years ago. So the integration with our hospital team, it's very interesting. I loved your talk. Slightly different perspective in an integrated model. I'm representing Mid-Atlantic states, so that's the DMV, Baltimore, Maryland, DC, Virginia. So this is probably similar to most diagrams, the complex care patient in the middle. I'll give a brief introduction, get to the heart of our sort of hospital managed patients. So the patient really is surrounded by the care of the complex care physician who's sort of leading the group. We have social work case manager assigned to each complex care patient, a nurse and a research nurse that helps collect the data. Of course, the goals and metrics, care coordination, increase health outcomes, decrease hospitalization and ED utilization. So that I think makes sense to all of us. So again, keeping the patient centric and the team sort of around the patient, where we can expand the scope in sort of the Kaiser Permanente integrated model. We have our own centers. We don't have our hospitals, as David mentioned earlier. We are affiliated with hospitals. So, for example, if you were to go to Holy Cross Hospital, which is our flagship hospital with almost every specialty care that Kaiser provides from our specialists rounding in those hospitals, you could walk through a floor and be confused that that is actually not a Kaiser hospital with the branding and things. So we've really spent a lot of time and intentional resources in our hospital system and have a great partnership with them. But we primarily, and interestingly, most of our complex care physicians are by training hospitalists. They were hospitalists for many years that when they said, okay, I'm going to take a leap of faith and start doing this sort of concierge level care and providing that one patient the care from our system. So primary care is in the medical facility. And then you can see the visitations are more of a social visitation. So whereas we have our own hospitalists that are Kaiser in our hospitals, partner hospitals, the complex care physician is like a specialist. So when the patients are admitted to those hospitals, we have carved out days in their schedule to make those social visits. That could be to a hospital, that could to be a nursing home, to a long-term care facility, dialysis facilities. Our research aspect of it, am I loud enough? You guys can hear me okay? Our research arm of it really helps focus in towards the multidisciplinary rounds. We do really well in getting the cardiologist and the endocrinologist and the patient and the complex care physician on the same call, and the same sort of, and that's sort of a virtually driven protocol. Home health, we work very closely with home health, home visits, coordination in the community for resources through social work. So this is probably not so much of a surprise to you, but I wanted to put this because I think it helps explain the care that we provide for patients in the home. Sort of the way our team is designated with our physicians and the research support, and then the case management support and social worker support. So every physician has a support system, and I'll tell you, the nurses and the case managers probably know those patients better than the doctors do sometimes. So how is our system broken down? So you can see in the map of Mid-Atlantic, between Maryland, Virginia, and Baltimore and DC, the red crosses are where our hospitals are. And as I mentioned, we don't have our own hospitals, we have partnered hospitals. But each of our hospitals has our own Kaiser hospitalists who work very, very well with our complex care physicians. These are all the different centers that we have. You can see we have 37 Kaiser centers in the DMV. They're equipped with advanced urgent cares. Advanced urgent care is a way I would explain it in sort of a layman's way, is like an urgent care on steroids. So essentially an observation unit where patients can be held for close to midnight. And so we're able to take care of a lot of patients that would otherwise go to the emergency room. So you may say, oh, yeah, that's a huge advantage, and it certainly is. But we do find those patients that we cannot take care of close to midnight because at the end of the day, it's still an urgent care. We have to send those patients to the hospital, and then they're managed in the hospital system. So my last and final slide, and then I can answer some questions, is that we use our advanced urgent cares for a lot of the acute interventions that traditionally could be sent to the emergency room. Also, we employ prepatriation. Prepatriation is when somebody is at a hospital emergency room, our case managers and social workers can reach out to those emergency rooms to say, we see that you have one of our patients. Will they meet criteria to come to our urgent care facility? And that's for like chest pain rule outs, TIAs, pre-DK, dehydration, whatever it may be. If they meet that criteria, we bring them back into our system for our own emergency medicine doctors and our own complex care doctors to see together. So on a daily basis, we do have a sign out that's between the CCP physician and the hospitalist. So we get every morning, there's a refresh report of where our complex care patients and which hospitals they are. And there's a carved out time in the beginning of the day to make that phone call and communicate with the hospitalist. And 99% of the time, our hospitalists will reach out to the complex care physician. There's only 9 of them, right? In a 1,500 physician group. They'll reach out to them and say, I have your patient. And so there's a communication that takes on throughout the day. And again, I think David mentioned this in his beginning remarks, and I really love that relationship with the patient and relationship with your colleagues that are helping manage that patient. So that really, I think we've really tapped into that. And so we have a care coordination with our CCP team. Our case managers in complex care and our nurses work with the hospital case managers and social workers to get around the care coordination of that patient, specifically time of discharge and when the patient is seen. The CCP team has a weekly huddle in which patients that are currently still hospitalized in the system, we come up with care coordination plan, which is then shared with the hospitalist and the hospital team of how we can collectively work to help get that patient out of the hospital into the ambulatory care. And that's sort of a multidisciplinary approach. We use our outpatient specialists, whether it may be cardiology or palliative care, to chime into those conversations. Those coordinations can be in person. There's a designated time in our hospital system that we've created between 12 to 1, and not everybody loves that, but to discuss those patients and bring our specialists to the table, including the complex care patient. Then there's a daily admission report that goes out regionally to all complex care nurses, case managers, and physicians to let them know who's admitted where. And then the last thing I'd like to point out is that whereas we don't, our complex care physicians, we're mostly hospitalists, working primarily now in the ambulatory setting because their patient load is enough that they probably can do most of the work in the hospital system. They do reserve some time in the week to do social visits. And they use this time to be sort of consultants in that space. So they will go in and see those patients and very often enroll new patients. So if there's somebody that meets the CCP criteria being hospitalized and not currently in the program, our physicians will do a quick sort of meet and greet and empanelment in the hospital itself. That's really a great efficient way. But again, we do that from the ambulatory space as well. And then the last but not least, I mean, there's a lot of metrics that are currently been put in place. We talked about like the stay, ICU days, time to hospice. the disposition of the patient starts on the day one of hospitalization. So as a part of our efforts for the care coordination, there is a continuous sort of follow-up and feedback loop around patients' discharge that goes on through secure chatting in our Epic. And so the hospitalist and maybe somebody from the team is usually involved. The complex care physician, the complex care team is usually involved regarding follow-up care. So there's no patient that leaves our hospitals without having already an appointment in place and a way to get to that appointment. So we've done these things well. Despite of all of this, you could say, oh, this is great. These resources are great. We find our data very similar to the data that David had presented. So it's really there's something there, despite of, you would say, oh, you might have better data or better outcomes. For our dual patients, we've seen exactly the same, the utilization, the cost for those patients. Our patients are living longer. We've still got to figure out the quality of life of that. But to have those patients living longer is an expensive product. So we're now finding ourselves dealing with that and figuring out how can we show the quality of life improving for our patients. But for the purposes of my talk, this is sort of our integrated approach to managing hospitalized patients. We don't manage those patients. We're more consultants and help manage those patients. Thank you.
Next.
Thank you. Yeah.
Oh, sorry. So I forgot I had like one last slide. So this is our this is our inclusion criteria. As you can see, it's quite advanced. What serious illness means for us in Mid-Atlantic is that we've had some AI data put in place for our patients that predicts their mortality score. So those patients have a much higher risk of mortality in 2 years. And so obviously admissions, and obviously metastatic cancer, end-stage renal disease, CHF, neurocognitive disorders, and hypoxic respiratory failure. So this is our attachment of patients. Sorry about that last slide.
Thanks. Can everyone hear me? Okay, I'll just speak up. So I'm Shivani Sanyal, and I'm here with Chris Brody. We're from Rush. So our ideas are very much in the early development stage of our model. Kind of started at this conference 2 years ago, and really before that even, I think, this helps, thank you. Chris had been in talks with other providers at Rush before we joined, and then at this conference in 2023, we began more regular talks about developing a model at Rush, which makes sense with our strengths and our resources. A little bit about that. So I liked that in one of your objectives earlier, Andrew, you talked about like leveraging strengths. So in our model, we are leveraging the strengths of our existing hospitalist system and our Rush at Home complex care primary care system. So we'll talk a little bit about both teams and how our idea is to kind of partner them more, strengthen the partnership between those two teams. So the unit where we have multiple hospitalist teams, as does many systems. The unit that we're focusing on is the 7 North team, often an area of experimentation in our hospital, I would say. It is a team that has dedicated multidisciplinary members. So we have multiple APPs. It's a 6 APP total team with any 2 working at any given time. We have 2 physicians, one working closely with the APPs on their patients and managing 6 other patients, and then another attending that does 8 other patients on that unit. We have a dedicated pharmacist and a dedicated case management team with 2 nurse case managers and a social worker, and then a nursing team that is for that unit. So the geolocation of this team is very important. and sees a total of 32 patients. On the outpatient side, Therese Byrne will speak a little bit more about Rush at Home in the next section of our conference. But just to introduce Rush at Home, it is a small group of primary care providers who provide care in the patient's home for patients that are homebound or particularly frail. And there are many advantages to this model. They provide in-home primary care. They provide care coordination with home health agencies, social services, and other providers. They can do blood work, in-home x-rays and vaccines, refill medications, order DME, and advanced care planning. And this program has been at Rush since at least 2018, so they're pretty well established. And they have done a lot of studies on outcomes and have shown good outcomes for these complex patients. So this is already a cohorted group of complex patients with medical complexity and social complexity that we decided to partner with from the inpatients. So this is a little bit about Rush at Home's referral criteria. They're adults with difficulty leaving home with multiple chronic diseases, recent emergency room utilization, lives on the west side. So this is kind of the area we're focused on. And then patients served since 2018, about 630 patients. There's around 400 active patients. You can see the age range really wide. It's one of the only Chicagoland home-based programs that does serve patients under 65. And focused primarily on the west side. So our model is to strengthen the partnership between these two programs. So the idea is when Rush at Home patients are admitted to our hospital, we want to geolocate them on the 7 North unit. And then on hospital day 1, start a close communication through our Epic secure chat system between the inpatient and outpatient teams. And it's really encompassing the whole team. We talked about how important it is to, incorporate all disciplines in these teams. So that would include the hospitalist, the advanced practice provider, the 7 North PharmD, who has been an integral part of this development of our model, our social worker on 7 North, our case manager on 7 North, and then the Rush at Home primary care provider and social worker as well. And then during the hospitalization, the idea is that we introduce ourselves as partners of the Rush at Home team to the patients, hoping to, build that trust that we all are working together in the care of these patients and kind of adding to that continuity of care. And then also, I forgot it. The idea being where we want to really have the outpatient team serve as active consultants on the care of the inpatients. So that's what kind of this communication is supposed to be. It's not just a, hey, heads up, like your patient is admitted, but we really welcome the information and expertise that this Rush at Home outpatient team has on these patients in, informing the management of these patients during their hospitalization. So there's really joint planning and joint care throughout the admission, the hospitalization, and at discharge. Really with a lot of focus upon discharge to make sure that there's appropriate needs addressed at that time. So this model we've developed over a series of meetings, and we communicated this model to our hospitalist division, which is a pretty large division, to try to stakeholder buy-in. The one thing I'll note is the 7 North unit is a little bit smaller. So I talked about having 6 advanced practice providers who are on that unit at any time. And then the MD cohort is also smaller who work on that 7 North unit. So we kind of started a pilot in the beginning of December. We're just really testing the waters with this. So this data that I will present is not that great in the fidelity of our process, but hoping that we address some of these challenges. So kind of 2 months into the model, we had about 30 Rush at Home patients admitted to a general medicine service at Rush Medical Center. So this could be over any of the general medicine service, and we'll talk about how many of those were on 7 North. So one part of this is that the cohort of patients we're working with right now is fairly small. So I think that is both a challenge and a strength, and we can go forward with that. So there was a total of 40 separate admissions with multiple patients having multiple admissions. 12 of the 40 admissions were on 7 North, so that's only 30%. But for 8 of the 12 of these admissions, there was documented communication between the inpatient and outpatient teams throughout the hospitalization. So we can talk a little bit about the strengths, challenges, and opportunities that this model offers. So the strengths are, it's a partnership between an established outpatient complex care team and a dedicated inpatient unit with no additional cost or resource use at this point. There's inpatient continuity provided by the small group of advanced practice providers, the PharmD, the social worker, and case management from the inpatient side, and of course, the continuity provided by the outpatient Rush at Home team. The challenges has been geolocating these Rush at Home patients onto 7 North. We have a complex system of admissions, both direct admissions and through the emergency room or transfers from like a de-escalation of care from the ICU or transfers from other hospitals. So it's been challenging to try to figure out how to bring these patients onto this unit. And then we have it's a small cohort of patients right now, around 400 patients total. So at any given time, there's about 4 or so patients hospitalized on a medicine service. So being that it's a small group of patients, it's harder for our hospitalists to kind of look out for these patients when they're on this unit. So opportunities, we've talked about doing joint rounds with Rush at Home providers via video conference. So bringing in an iPad sometime during the hospitalization and having joint rounds with the inpatient and outpatient provider to really emphasize that active consultation from that team. We have a Rush at Home pharmacy patient education order that our pharmacist from 7 North has created to support patients as they are getting ready for discharge to make sure they have all their medication questions answered. And then in the future, we're hoping to measure outcomes similar to some of these operational outcomes we've talked about in the past, but also patient and provider satisfaction, the trust patients have for their inpatient providers, given this slightly different model. I think that was most things I wanted to talk about. I think there's potential in the future for involving other patient groups. So like if this model works and if we are able to do this well, we can partner with geriatric groups or other complex care patients groups. So as a med-peds provider, I'm interested in adults with chronic illnesses of childhood. That population often has complex medical and social needs. So I think there's a lot of potential for this model to really serve patients with multiple different needs. And also for my peds life, there is similar models in complex care pediatric settings that have been studied and have shown really good outcomes for important like hospital level operational data like length of stay and like PICU visits, costs, and 30-day readmissions. There was one randomized controlled trial that was actually done in Texas that looked at active hospital consultation from a complex care pediatric clinic for these patients when they were admitted. So obviously, different challenges with adults and peds, but it is promising to see that there's these models being studied in different settings and different life ages as well.
Stand up. Hello, everybody. It's nice to meet you. I'm Ed Vasilevskis. I'm the division chief at University of Wisconsin-Madison. It's awesome to be here. I wanted to do a shout out to Dr. Hummel, who is one of our clinicians who has joined us on our team. And I was here with a couple of colleagues speaking of the fusion of innovation. I originally started at Vanderbilt University, and we had a program originally called the Vanderbilt Familiar Faces. Then it turned into the Vanderbilt Inpatient Care Program, Interdisciplinary Care Program. Sorry, Francis. So one way to diffuse innovation is you move. And so I landed in Wisconsin in October, two Octobers ago, and that's when this conference happened. So exactly 2023. And at that point at Wisconsin, we did not have any type of comprehensive care program. We didn't have a single provider enrolled, didn't have a single patient enrolled. So hopefully what we show you is that you can do something, hopefully in a relatively quick period of time, going from what Tyson Heller would say, going from zero to hero. And so we'll give a little bit of description of that. So no disclosures. I do want to disclose that we are partly funded through our CTSA. We have a project for which we're doing some research on this project. So we're excited to share some of that prospects as well. So as I mentioned, in October 2023, there was a new division chief at University of Wisconsin-Madison. And guess what? When you're new, guess how many relationships you have? 0. Guess how much trust you've built up with the medical system? None. And so that notion of power structures and relationships really is important. It actually goes into why we started the model the way we did, because our model was really designed with what do I have the most control over and who can I build up trust the quickest with? And the quickest people I can build trust with is my own team. And I don't have to worry about the outpatient providers and the nurses and the CEOs. And of course, I do need to worry about those things, but we want to build those things up over time. So our model is really, not only was it, with a new person trying to drive this, I had to be really cognizant about who we were trying to build relationships with. So in October, we were in the contemplative phase. We did not have a comprehensive care model, and we didn't have a team. Just to give you some background of UW is a little bit different, and it was different from where I came from in the fact that we have 2 hospitals. We have the main university hospital, quote unquote, downtown, and then we have the East Madison Hospital. Our hospitalist providers provide care at both hospitals. We're constantly switching back and forth. We have about 14 teams across both of these teams. And like many hospitalist teams, you first started with 1 team, and then you got 2 teams and 3 teams. And next thing you know, you have 14 teams. And unlike Rush, most hospitalist programs are actually not team-based. 1 week you're on team 1, the next week you're on team 3, the next week you might be East Madison Hospital, the next week you might be doing admitter shifts, then you're doing nights 1 week. And it's one of the things that hospitalists really enjoy is the variety. It's one of the ways we can help retain clinicians is by kind of mixing things up over time. And at University of Wisconsin, that diversity is even furthermore because we have these 2 hospital systems, which are really, patients are shared back and forth between those 2. And in fact, you can admit a patient at University Hospital downtown. I will see the patient in the ER, and then I will send them to the East Madison Hospital on the basis of the resources that are available, and vice versa from the East Madison Hospital to the downtown hospital. So when you design a system and you're trying to maintain that continuity, it creates a little bit of additional challenge. So what's the problem? As noted, in the traditional system, you're a patient who gets hospitalized 3 times. You're first seen by me. Then the next time you come to the hospital, you're seen by a different clinician team. And then by the next hospitalization, you're seen by a different clinician team. So we in hospital medicine, not only have we increased fragmentation because of the inpatient to outpatient, but even within those hospitalizations we've created fragmentation. So the problem we're trying to solve, of course, we do think that the overall CCP model is it's really the gold standard from my perspective. However, there's still problems to solve within hospital medicine itself. Once again, just from a standpoint, if you have 3 admissions, we have 11 teams, your likelihood of being on the same team, let alone the same provider, is well less than 1%. 1%, the same provider, you won the lottery, right? You really have. So our opportunity is really to kind of change this model of care from our fragmentation, taking along these patients that we think that those patients, similar to what a lot of these other programs, that every single patient doesn't need to be on this single-based team with the same providers, but really matching them with our high needs, high complexity patients. And we think that this is going to yield satisfaction, not only with our patients, but also our providers. Because when you see that patient who came in for the 3rd time, I look at their chart and guess what? The patient says, why isn't Dr. Hummel taking care of me? And I say, well, Dr. Hummel actually is over at East Madison Hospital, right? So Dr. Hummel did such a great job. And so now I'm fighting an uphill battle. And vice versa, I'm wondering, how did Dr. Hummel do it? So I have to go through the chart, I got to figure everything out. And so that notion of reinventing the wheel, we're really trying to grease those wheels from the standpoint of our providers as well. So what was the opportunity? So one of the first things we did is we had to identify, does this actually make sense at University of Wisconsin? I suspect there's enough patients with hospitalizations. And in fact, we looked, 1447 patients had 2 or more hospitalizations to a hospital medicine team at our university hospital in the past year. 510 had 3 or more. So we thought there was ample opportunity within our hospital system to be able to enroll enough patients to be able to make a meaningful change. We are ranked at UW Health, so this is hopefully not being recorded. And this is not the way, oh, this is the way, obviously, we get resources. Like, we're 84th out of 116. So we have a ways to go to try to improve care from a standpoint of readmissions. We all know that these patients, the 5% of patients take care of 95% of the resources. So from a sales perspective of trying to get our CEOs, CFOs engaged, our argument is these are really expensive patients, and work that we did with Francis and the team at Vanderbilt showed that these patients, 99% of the time, they came back to our own hospital. They're not hospital shopping. They come back to us over and over again. This is our problem. We need to own this problem because they're going to come back. So I'm going to hand it off to Dr. Westergaard, who I'll tell you, as somebody who I'm just a champion. That's all I am. This is a great idea. I got sold into it when Dave presented probably something more than a decade ago. I was like, this is just common sense, right? Why aren't we all doing this? And then there was an opportunity at Vanderbilt to do it, but it takes people. It takes people to run this, and Dr. Westergaard is the person. So.
Okay, so with that kind of background information, I'm going to talk to you a little bit about our approach and just for some background on how I kind of got involved in this. So I'm really interested in kind of the workforce aspects of things and how we can optimize our workloads and models of care. And so when Ed came to UW, it was kind of this like perfect opportunity for the two of us to work together to launch this team. And so our first step was to build our team, and we were very intentional about how we did this. I know there's been a lot of talk about getting people who are very interested and want to be a part of this team, also creating a small enough team that we would develop like a shared mental model, but large enough that our scheduling team wasn't totally frustrated with us and getting or being able to make that schedule. And so we approached people who expressed an interest and recruited people as they were interviewing for positions, told them about the team. And so we have a really nice mix of some experienced hospitalists, some relatively new hospitalists, and then we also recruited 2 new APPs to be part of the team as well. Our next step was building relationships and aligning with our health system goals. Ed already kind of talked about kind of getting that stakeholder buy-in in terms of our readmission scores, knowing that we had the patient population. I was also fortunate because as having a new division head, he was on a bit of a publicity tour or kind of, making the rounds. And so he was obviously very invested in this team as well. And so would drop little seeds with every health system leader that he would meet with. And so it was very easy for me then to go in and kind of follow up and set up different meetings with folks. So we were able to get a lot of institutional support and buy-in from our health system. The next step was just identifying the appropriate patient population for the team. As Ed mentioned, we were able to identify in some preliminary data that we had over 1,500 patients who met or who had over 2 hospitalizations within the last year. And we wanted to build the team so that we weren't overwhelming the inpatient team with what we were calling our PHP patients. And so at the same time, UW was rolling out a readmission risk score through Epic. And so we were able to use that to kind of leverage or guide how many patients we wanted to enroll in the team. So we were using patients who had 2 or more hospitalizations plus a readmission risk score above a threshold, and then we're able to adjust that to kind of meet the recruitment numbers that we were looking for. We decided to exclude patients who had a UW Family Medicine PCP simply because our UW Family Medicine residents have their own inpatient team at UW. And so they have, in a way, their own kind of PHP model to an extent. Some of their overflow patients end up coming to our team, and it just was going to get too complicated and messy. So we ended up excluding them. We also were excluding patients with a primary cancer diagnosis. We have a separate oncology hospitalist service that primarily manages those patients. also excluded pregnant patients and then incarcerated persons from our population. As Ed mentioned, we also wanted to study this a little bit more rigorously, and we had a really great opportunity with our CTSA. I think it was a month or two after you joined, there was an RFA for a learning health system demonstration project. And so we kind of very quickly put in a letter of intent for this and submitted a grant last May, and fortunately were selected to be funded for this. And so as a result, we've designed a pragmatic clinical trial to study the implementation of our team, have built a BPA within the health record to identify eligible patients, to randomize them either to our PHP team or to a usual care team, with our primary outcome being feasibility. So identifying what proportion of patients that we've enrolled and randomized to the PHP team once they get readmitted are actually getting readmitted to the PHP team. And then complementing that with some exploratory outcomes, looking at patient and provider experience. So our progress to date, so I realized in hindsight, I started this timeline in October of 2024, which is when our grant started, but we had been working on this probably for a year before that, when Ed arrived to UW. And so the year building up to that was creating the team and getting some of the stakeholder buy-in, submitting the grant, et cetera. In October, our grant started. We, by this point, had all of our clinical team onboarded and in place. The schedule was in motion, and we were creating the BPA, which I will get to, has kind of been probably the biggest thorn in all of it. It's been a bit of a headache and has kind of delayed some of our process. In November, we formalized the research team, had added a human factors expert, some qualitative researchers, and got that team built. The BPA creation was still ongoing in November. In late December, we were initially able to launch the BPA, however, within 24 hours. Very quickly realized an error with how the BPA was working. And this, I think, happened on Friday, December 21st. And so going into the holidays, we had another 2-week pause. But we were eventually able to launch the BPA on January 9th and started enrollment. As part of the grant, we were also able to add an RN case manager who has been great. And they got started in January. In February, we've been continuing with enrollment and have been having weekly clinical team meetings, and then kind of in the future, planning to do more of the qualitative evaluation and some meetings with stakeholders. So very quickly, I'll kind of go through facilitators, what's worked. Again, we had the stakeholder buy-in. We were aligning with our health system priorities. I have a dyad partner who's the director of the care continuum at UW Health. That was part of the requirements for the BPA or the LHS project itself. And so she's been very helpful and supportive. The CTSA team itself has been supportive. We have a very engaged clinical team. Again, I can't emphasize enough how important it is to have people on the team who want to be on the team. And it just makes my job a lot easier. And then the case manager that we have recruited just has a ton of experience, institutional knowledge, and then also experience with care transitions. Our biggest barrier, as Ed had alluded to earlier, was controlling the message. So there was a rumor that was spread last summer about through the nursing staff that we were going to overload this one unit with all of these patients, and had to do a bit of damage control to reverse course on that message. The BPA build, again, has just been very slow and cumbersome. This is a new build that our informatics team and analysts are working through. We also have very limited geographic localization at our hospital, and that has limited continuity with nursing and our discharge planners who are unit-based. In an ideal world, we would be more geographically localized. But we have a lot of system and capacity constraints, again, with our 2 hospital systems and the acuity with both of those. And then lastly, just launching a pragmatic clinical trial in a complex environment with a lot of protocols and bureaucracy has been quite challenging as well. So that is our experience in a nutshell.
So great to hear so many different approaches to trying to solve the same problem of continuity and improved care for these complex patients. Looks like we've got about 20 minutes left. And I definitely want to give the group plenty of time to ask questions. But before I do, I just wanted to ask sort of one big framing question, to sort of compare things across these groups. What would you say is most essential to your model? What do you think is its core that really makes things work? Could be a couple of bullets too.
I'm never hesitating this. I think that one thing you probably heard is teamwork really is the dream work. And so that's just getting the right team in place and just really being able to identify it. You may remember that when I was here in October, I had 4 different people who are not here today. It's not because they're not fantastic clinicians. They were excited. They think the idea is fantastic, but actually none of them are on our PHP team. This was not the work that they were working. And actually, the interesting thing was 2 of those individuals. Okay, so Justice. Okay, but 2 of them specifically said, Ed, I think I would go in too deep. I think I would get too involved, and this would take over. Because they were so invested. And so it was interesting that one of their concerns was, this can be, this can take over potentially some aspects. And so that was, and so I said, that's like, I thought they would be the perfect clinicians, but they actually said, I have a family and I think I might get too involved with the patients. And so maybe they're going to come back and maybe they'll be fantastic clinicians, but at this moment in time, it wasn't right. 2, I just think that this story is so easy to tell. Hey, we got this program where if you get hospitalized, we're going to put you on the same team. And most people say, well, doesn't that happen already? Right? And so I always think the best ideas are the simplest ideas. And this is just such a simple idea, right? It's just old primary care. And why don't we do it? Like I said, I think it's just because we just didn't, we just added 2 teams, 3 teams, 4 teams, 5 teams. And next thing you know, we had 14 teams and nobody thought to set up more team-based care. And so I think the message is pretty easy to sell. Now the economics is not easy to sell and the value proposition, but the idea is very simple from that perspective. So I like that. And then I would just say the third thing is, gosh, all it takes is a couple of patients where where they see the same clinician or the clinician sees them. And so we do need, Dave mentioned really early on, we need to do a better job of telling these patient stories because they really are, I think they impact both the patients, but they also, I think, impact the clinicians in a really powerful way that drives it forward.
I was going to say, I think, like you were saying, like simple ideas, right? So we are really leveraging the trust that Rush at Home has already developed with these patients and the knowledge that they already have of these patients, and we're really just partnering with them. So I think that went a long way in the patient experience, also the provider experience. It works both ways. And like knowing all of the context that happens outside of the hospital immediately upon admission for the provider, and that knowledge being transferred to the patients. Like the patients know that we're aware of what's happening outside in their homes or in the care that they receive outpatient, I think is what would be the strength of this model going forward.
Very, very similarly, I think the right team really is the generic answer, that the right physician and to empower that level of autonomy amongst each one of the providers and the staff to care for the patients and really trust them with that. Interestingly, for us, I had a vacant position for a year to just fill it up for our Capitol Hill Center. And it was, again, a hospitalist who sort of came to the discovery that they were looking for something more than the 7 on, 7 off. And then the continuation of care when patients like left the hospital, what would happen to them? Because they were seeing the same patients for the life. And again, to develop a program that's successful and meaningful, and then the folks that work in that program, that run that program, speak highly of it and brag about it. So taking those moments to really highlight the great stories, the things that come from all the heartache that goes along with it too. So I think that's really, really important. So yeah, kind of a generic statement, but I think all of that really holds a lot of value into having a successful program. Again, for our group, we try really hard to like promote the autonomy amongst physicians. And when our physicians are in the hospital or in the SNF and other places, they speak of that. They speak to the value of caring for that patient, knowing that patient's family members, and going, being invited to their parties or speaking at a funeral. I think that really resonates. And over the years, for any practitioner, whether it may be somebody in the ambulatory setting or in the hospital, they find that that's meaningful work.
Let's open it up to the group. What questions do people have with this team of innovators?
The two of you who seem to have, to me, I might have misunderstood the structure, but it sounds as though you have very robust support teams beyond the physicians. And then you have outpatient PCPs and inpatient hospitalists that rotate. And I'm wondering, is it possible for you to advance because you call it complex care as opposed to comprehensive care? I'm wondering, can you advance it then to have some segment of those hospitalists become CCPs and truly only see their own patients, or do a rounder model that allows the same hospitalist to continue to see that patient as they're readmitted? Because it seems to me as a family practice physician that would even enhance the program further with continuity.
So I'm gonna perhaps like a two-part. First part is organizational support. And I think that's something I don't want to touch too much on. I think we're not different than any other organization in which we have to appease to the model of utilization and, getting CEO level support to have something running. This is an expensive program to run. And so I think what I'm used to in my years of practice is that, what's the award for doing good work is to get what to do. And so I think that there's the physicians have figured out a way to continue to do this work in a way that they can. With regards to that sort of hybrid, we've looked at the idea, and because our attachment of FTE and staffing complex care really seems like comes mostly from the hospital-based system and the hospitalists that want to do this work, is to have areas of where we do see a lot of patients in our hospital setting. Is there sort of a champion within the complex care system? We can't have our complex care doctors go to all 13 of our hospitals. It's almost impossible.
Sure.
So the system runs really well, having the hospitalist take care of that patient, whereas the complex care physician is sort of the consultant and always available to help guide that care, even if it's in the hospital or a skilled nursing facility, et cetera. So we have looked into the idea of maybe in the future developing sort of champions in that space. Now that champion could be somebody who's designated to see maybe a few less patients than an average hospitalist that would see, 12 plus patients. Maybe they could see 6 or 8 complex care patients in that one cohort. So we've looked into that idea. We do have support around that. But then just to maybe look at the challenges and expectations of that physician and that router, because the hospital can't guarantee that. If you have over 100 patients hospitalized and then, that somebody needs help, then that champion is saying, well, I'm just doing the complex care patients only. So we are looking into that. I don't think that's off the table, but we're exploring that.
Thanks. I was just curious what the obstacles might have been.
Yeah, no, that's great.
Thank you.
For like our system, I think since we had such a strong outpatient groups already in place, like the Rush at Home program, our geriatrics program that take care of patients with more medical and social complexity, we were less inclined to like start from like a truly traditional comprehensive care program. But I do see like there's potential for like a rounder model in the future. I think the rounder model is both, adds this patient provider continuity, but also it's like a different work model for hospitalists in general. So I think that may be several years down the road, but definitely thinking about like different models of hospitalist work structure is important going forward, because I think, at some points in people's lives, like the 7 on, 7 off may not make sense anymore. So like, some of the strengths of the rounder model is that more regular scheduling. So if we were to create partnerships with other outpatient groups, like, and be able to expand this cohort of medically complex patients, perhaps we could have that team entirely be more complex patients, maybe a smaller census, similar to the rounder model. And I can see it going that direction in the future.
Thank you.
I have a question. I'm not sure this is the right group to ask it to, but maybe that makes it the right group to ask it to. One of the big crises that the United States is facing is incredible decline in the number of primary care doctors. Fewer and fewer people are going into primary care. Primary care doctors are retiring, so there's going to be a huge shortage. And I'm wondering if you could comment on how that's playing out in your system and what that means about the demand for sort of a full comprehensive care model in your system. And if that demand were to exist, who it would come from. And I'll bias your answers with the following comment. When I think about who benefits from CCP, like whole thing, and I'll take rounder as a step towards it, I keep coming back to one thing again and again. It's patients. And, not only could they benefit, but they're coming from a point of, being profoundly underserved and with a huge social risk that that scarce resource of primary care is going to be allocated to the people who need it least. And so I'm just wondering if you could think about your own programs in the context of this large transition we're going to go through in the next, well, we're going through it now, but it will intensify over the coming decade.
I mean, I'll just say I'm still learning the market in Dane County, which is where where University of Wisconsin-Madison is. And one of the things we can and should look at, first of all, is we're taking anybody, regardless of their primary care status, onto our team. And one of our goals is to build better relationships with our primary care physicians. But we'll want to look to see how many of our patients actually don't have primary care. I can speak from our experience before at Vanderbilt that our full intention was to start a CCP model where all the patients were inpatient, outpatient, but in the end, only 10%, about 10% of the patients were actually full CCP. 90% were more of this primary hospitals provider model. And so that meant to me that there wasn't, and part of that was that they didn't want to engage with primary care. Part of that's because they are so distant. And so there's lots of different reasons. And so that's where I get a little nervous about the full comprehensive care model in Wisconsin, about how many patients are there that are really going to want to see us in primary care. So let's get the hospice model right. I do think that patients really would benefit from this, but understanding the market is important. And then, everything's local. Wisconsin's a pretty rural state, and so there's patients from all around. And so this notion of technology and how to harness technology, I think, is something. And rural hospitals are closing left and right in Wisconsin and Tennessee, any place that's, and if Medicaid budgets, these are all issues we're going to have to deal with. So it's a really important question, but I think technology is going to be part of the answer for sure. And then the use of paraprofessionals, I think, is another answer from a standpoint of of using paramedics for which they're doing in home-based hospital care to provide those touch points and intermittence. And we're going to have to really get creative about how to reach people in their homes before they get to the hospital.
And can I just make one quick comment on that?
Yeah.
I agree with you completely in your setting. I do just want to point out that you don't need to do CCP for everyone to do CCP for some people.
Oh,
Right?
absolutely.
And like, if it's 10%, awesome.
Yeah, I think you just need to have enough that you can fill a clinic.
With the right people.
Exactly, with the right people, and so.
And that's sort of the flexibility with Rounder
Yeah.
is you can sort of add that instead of other
Yeah.
clinical chefs.
Yeah, I was just gonna add that, I don't know if this was already happening where we started to see a shortage of primary care. But we were not, in Kaiser Permanente, we were not immune to the Great Resignation either. And if I misquote, I apologize. I think it was like 7%, but for us, it was close to 5% of resignations, and primary care was a big part of that. How it affected us in our organization is that I think there was a increased burden put on complex care to go out and maybe perhaps expand the criteria and perhaps work in a consultant manner. So for example, and I mentioned this earlier jokingly, but I was kind of serious about when you do something good, you're asked to do more of it. Like, so if the complex care program did well in care coordination or sort of primary palliative care measures, then there was an ask to do more of that, not for complex care, but for the organization. And I think what that does in the long run is take away from that small cohort of patients that we do really help. I mean, there's an inclusion criteria for a reason. And I think then if you don't stick true to that inclusion, then you may not be able to help those specific patients. So again, to be determined, I think things have gotten better. We are starting to, again, hire up again. But yeah, I think in times like that, you're able to do more of what you do well, but may not be able to help that specific targeted population.
I'd like to build off of what you guys are talking about in the target population. Just as I was listening, it might be I just want to make sure I'm hearing who are the patients. We talked about core elements. Who are the target core patients? So I think I heard in Kaiser, you have a really detailed list of eligibility, which also includes some AI modeling.
Yes.
I heard from Rush that maybe you're starting from Rush at home patients and building. And then maybe Wisconsin, I'm hearing it's the people coming to the hospital, and there's probably some hospital. And then I heard, I'm assuming Rounder is like what we heard from David, which were Medicare-based patients that had come in. And so am I correct in how I'm listening, but can you comment on who you think is the core patients you're serving and how you're defining that? And maybe a sense of what proportion of patients that is. Is it the 5% literally, or is it, that will help, I think, too, as we think of the generalizability of your models. Yeah.
I can start with Rounder at U of C. Since we don't have outpatient partners yet, I think it's really been the most complex inpatients. So patients who are here for a really long period of time, especially those with complex social and legal needs, as well as those who are frequently readmitted, especially those that really don't have much of an outpatient connection. We've got many patients who come into the hospital frequently who have never really seen a PC. Set them up with one and they still don't see them.
So what proportion is that in your mix?
It's a pretty small number of patients, but it's a significant enough number of patient days. So yeah, I'd say there have maybe been 10 patients, over the past year or two that really, really needed Rounder services. Most of the team is made up of just regular general medicine patients who I think still really benefit from the in-hospital continuity of only having one doc. But there have been 5 to 10 who we've really pushed towards that service because of their needs.
Others, can you just a rough sense on, is it a...
I was just gonna say, and I think this is partly what we're hoping to get out of our study too, is we have using frequent hospitalizations, right? So at least 2 hospitalizations plus this readmission risk score, which incorporates a lot of like social determinant of health factors as well. And so hoping with some of our data, at least our preliminary data, that we'll be able to identify like which patients is this having the most impact on, so that we can then kind of tailor the team a bit to try to enroll or recruit patients that we think are going to be the most beneficial in terms of patient outcomes, health system outcomes.
Yeah, I think the common denominator is the high utilizer patients, I think amongst all of us. For us, in KP, we've had about 6,000 patients go through the program. We currently have somewhere around 1,600 patients currently enrolled. We have a very high sort of mortality of these patients. The AI generated inclusion for our patients with serious illness, that's about 60% of our cohort currently. And these are patients that are predicted to have a very high mortality. And so it just, and you know, obviously, I think this won't be news, but patients utilize towards the end of their life the resources. And again, so a lot of things have put into place for complex care, like advanced care planning. So when you are enrolling into complex care, these are conversations that are had in initiation of enrollment. We can talk about that another day. Sometimes that goes well or doesn't go well, and there's a time and place for that. And then also transition to hospice from the time patients are enrolled into the complex care. It's a high utilization time in itself because there's a lot of interventions that go into surrounding that patient, at the same time gaining that support and seeing if you could have them come to the office rather than the emergency room to care for them. So
Yeah, I think to summarize, like there's like a lot of ways of assigning on a risk score for patients. And no one risk score probably determines if a particular patient will benefit from a model like this. So that makes it challenging. I think in the beginning, when we were talking about how to find the patients that would most benefit from a model like this, we were in close communication with Vanderbilt, and they had like a risk score as well at their institution. And we weren't entirely sure, like, is it just utilization, like are the ones that are the most frequently admitted? We didn't think that particular cohort were necessarily all of those patients were going to benefit equally either. So I think there's multiple factors to it. And we are lucky that Rush at Home does have a specific criteria as well that includes patients that have certain frailty scores, certain limitations in their home. So we partnered with a outpatient model that already enrolls certain complex patients. So we kind of went in that direction of partnering with, the outpatient team that already exists. But it is challenging, I think, to like figure out which patients will most benefit from a model like this.
Yeah, and I'll just call out the team from Vanderbilt, and Scott Lee was a clinician who really helped with. We did some work on an AHRQ challenge grant, looking at the data from the Vanderbilt population. And so part of we mentioned that we didn't enroll cancer patients because we had a separate team, but actually it was a little bit more than that. One of the other reasons we didn't enroll cancer patients was we found that these patients were the least likely to benefit from the Vanderbilt model. Because cancer patients have that high period of utilization and they either get cured or they don't. And so the model itself didn't have any effect on any of the outcomes of interest. And so we said, we know that this PHP model that we're going to try to build in Wisconsin, not only do we have our own oncology team, but guess what? I don't think it works all that well. And I know that Dave presented some stuff about patients with ESRD as being a particularly interesting population. And so I think there's a lot of work to be done about who benefits and who doesn't benefit.
So if all of you talk about these complex patients that you identify almost always in the hospital or maybe in the ER, and that's great because that's who you want to intervene on. But what I don't hear is about the outpatient side.
So is there anything that you need to do on the outpatient side, or does it already work? I mean, is there additional things that PCPs need to do with these kinds of patients that need to be added into the model?
I'll just clarify. I think for the sake of the presentation of hospital, I think that was highlighted, but majority of our referrals come from the ambulatory space and the outpatient. Majority of them, because I think the providers in the outpatient are seeing these patients. They don't have the resources or the time, the capacity to care for them in the way that they've seen how the complex care program. So our referrals come from that. Again, the challenge is even with that in our integrated model is to continuously have that communication loop amongst 1,500 physicians in the practice to say, this is the complex care program, this is what we do, this would be the right candidate. And so it really takes upon those patients. And some of the challenges we've seen from the outpatient space is that those patients don't necessarily want to leave their primary care doctor. They've been with them for years, and that's a part of their sort of established trust within the healthcare system. And so it really is the right patient, the right physician, and the coordination between the two. So that in itself also has challenges, but yeah, majority of our referrals do come from it.
Unfortunately, we are at time. But this has been a great discussion. Thank you so much.
Session will begin at 4.
Yes, that we're primary care issues.